the recording, and I will introduce our wonderful presenter. So we have, sorry, I'd never asked you, Leah?
Yes, that's right, Leah.
Crockett is a PhD candidate in the Department of Community Health Sciences at the University of Manitoba, who is studying integrated knowledge translation in child health. Leah is a trainee of Dr. Catherine Sibley, who's also joining us here today, who's the director of the KT platform at the George and Fahey Center for Health Innovation and assistant professor at U of M and Canada Research Chair in IKT in Rehabilitation Science. So we're very lucky to have this duo here today, especially I think we're privileged to have a PhD candidate presenting because they often bring forward a lot of innovation. And at Brandon University, we don't have a PhD program. So it's a real thrill to have you presenting for us today. So thank you.
Great. Well, thank you so much for having me on these last few days before the kind of official kickstart to summer. And as we said, it can be difficult to get people out at this point. So thank you to all of you who joined. And also thanks for introducing me. So while Dr. Sibley and I share our interest in advancing the science of integrated knowledge translation, our contexts are slightly different, with mine, as was mentioned, being in the area of child health. However, what this shows is that the foundations and principles of KT are widely applicable across a range of contexts, but that there is a huge evidence base upon which KT sits, and I've had the privilege to learn from Dr. Sibley about this expansive field. So before starting, I'd like to acknowledge that I'm coming to you virtually today from the University of Manitoba, which is located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Red River Métis. And I have the privilege of both working and learning on Treaty 1 territory. And this is where I now work and live. I was also born and raised in northern Manitoba. So I also want to acknowledge that I was born on Treaty 5 territory, which is home to the Aninuak and Dene people of the north, who prior to contact with the Europeans established and maintained important trade routes, connected with and lived off the land, and thrived in a culture that was celebrated through language, ceremony, tradition, and sustainable livelihood. And that this is very much part of my community, my background, and also influences the work that I do today. So the plan for our 45 minutes or hour or so together today is to break down exactly what we mean by knowledge translation, or KT. So I'm not too familiar with the audience here and what kind of familiarity you have with KT, but we'll start with kind of that basic understanding. Demonstrate how KT research can be integrated into existing research programs and provide some examples. Explore the synergies between, for example, qualitative research and KT, and of course, leave you with some resources. And I hope I'll leave you with the impression that KT is an extensive and growing field, and in fact, a science in and of itself. And there's a lot to break down. So today we'll really just be scratching the surface. So if there are any particular areas that are of interest to you as we go through, I'd be happy to dive deeper into those at a later date or point you in the direction of some resources in that area. So first off, let's just start with a very basic question of what is KT? So again, I know we have a small audience, but if there's anyone here who wants to unmute your mic or type in the chat box, kind of what is your basic understanding of what KT is? And I'll just give you a couple seconds here.
Nancy here. I'm intimidated by the speakers, though. Basically, my working definition is trying to take knowledge and get it to the appropriate audience in an appropriate way that they can understand, they can use.
Yeah, great. Anyone else? I see, I guess we only have one other person here. Yeah, getting information into the hands of those who can use it. Yep. Sorry, just 1 second here.
We're going to need 100% participation in this small group today.
Yeah, lucky you.
Thank you.
But yes, KT, I mean, KT is many things, and it's all of those things that you said. So it's using knowledge to inform healthcare, sharing evidence, creating partnerships and relationships, implementing research into practice. And we believe it's an essential component of the research process. So there are many ways of conceptualizing KT, and similarly many terms to describe what are largely overlapping concepts. So in fact, if you look into the literature, there are over 100 terms used, adding to this confusion of what is KT. So in the Canadian health research context, the CIHR, or Canadian Institutes for Health Research, definition of knowledge translation has become one of the most widely adopted. So you'll often see other funding bodies or research institutes referring to this definition, or reviewers looking to see that grant applicants understand KT through this lens. So CIHR conceptualizes KT as, it's quite a long definition, but a dynamic and iterative process that includes synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health of Canadians. And it acknowledges that this takes place within a complex system of interactions between researchers and knowledge users. So knowledge users are those who might use the evidence produced in practice. So that could be patients in the public, community members, healthcare providers, policymakers, etc. KT is also largely focused on packaging information in ways that are useful and easy to understand and engaging. So naturally at CHI, which is the Georgia Beatty Center for Healthcare Innovation, our KT media specialist often creates more visually appealing formats to convey key messages. So based on the CIHR definition, we like to use this visual, which breaks down the definition into these 4 components. So being the synthesis, exchange, dissemination, and application of knowledge. So whether you say knowledge translation or knowledge mobilization or implementation, the concept remains the same, and we're really looking to go from evidence to action, or more simply from what we know to what we do in health. And while visually it may look that the 4 elements are sequential and ordered, I think it's really important to remember that this is an iterative process. So sometimes you do some synthesis and then exchange and engage with stakeholders. That might pop you back into more synthesis, or maybe to dissemination and application, and so on and so forth. So it's not a linear process, but you can really kind of jump into the different stages as you're moving knowledge into action. Now, having heard the basic definition, or answering the what is KT, let's talk for a moment about the why of KT. So why is it important that we kind of couple KT with health research? So the answer that has typically been sort of pushed in KT, and we've moved a little bit away from this, but it largely emerged from findings from a 2000 study by Ballas and Boren that found that established evidence was taking an estimated 17 years to reach clinical practice. So I don't know about you, but 17 years is a long time. So if I think back to where I was 17 years ago, I was probably in elementary school or middle school. Either way, it's a long gap there. So this need for KT emerged really from the no-do gap between research and practice, and our understanding that commonly used strategies like one-way communication have had inconsistent and typically small to zero impact on actual use of research. And this knowledge to practice gap is important because it results in suboptimal patient care or poor health outcomes, evidence that doesn't reach those that it was intended to reach or who it might impact, and also considerable research waste. And in fact, the science to practice gap is represented by a number of staggering statistics that demonstrate, for example, that only 14% of research reaches a patient, and that it also impacts other knowledge users like administrators and practitioners, where only 18% report frequent use of evidence-based practices. So before I started working on my PhD, I worked as a knowledge broker for a national network in pediatric emergency care called SHREC. And this gap was also evident in this context. So in kind of my context of child health. So similarly, the original gap or problem that drove our work was that they found that 85% of children who needed emergency care in Canada were treated in general emergency departments that were not part of children's hospitals. They also found that 40% did not get treatments where there was clear evidence that existed, and that 1 in 5 may even get treatments which were of no benefit or even harmful. So this gap is often thought of from 2 angles. So the first being an inability to reach end users. So essentially ineffective dissemination or uptake by knowledge users. And the second is one of knowledge production, essentially that we're often asking the wrong questions right from the start. Although in reality, we do know that it's more complicated than that to, for example, change a healthcare professional's practice, influence policy, etc., due to a number of factors like organizational culture, resources, leadership, politics, competing demands. It's a complex process. But either way, CIHR typically breaks knowledge translation into 2 broad camps, being end of grant KT, or that dissemination piece at the end of the research process, or integrated knowledge translation. So these 2 types, integrated knowledge translation, this is where potential knowledge users are engaged throughout the research process. And it's thought that this approach should produce research findings that are more likely to be directly relevant to and used by knowledge users. And then the second end of grant KT, this is where the researcher develops and implements a plan for making potential audiences aware of the knowledge that's gained during a project. So end of grant KT can involve more intensive dissemination activities that tailor the message and medium to specific audiences. And even further along the spectrum can involve moving research into practice in cases where the strength of the evidence is sufficient. So for example, the results of a knowledge synthesis can often lead to actionable messages that can then be communicated to the relevant audience. So who has a role in knowledge translation? Well, there are many of them. We have patients, their families and caregivers, healthcare providers and staff, knowledge brokers, and policymakers, managers, and then the public, and then all the way over here, the researchers, and all have a unique role to play and need to be considered in the context of KT. But within the scholarly discipline of KT, some groups have been considered more than others. Knowledge translation is also viewed as a continuum, which has evolved over the years and continues to evolve. So a lot of people start over here on the left, and really within the field, we want to move further and further towards the right. So not everyone will get to this far right portion here, but the goal is to at least move from gray to yellow, and then there's lots of opportunity to move to this orange area. So many start over here on the left with this acronym that we've referred to kind of as it seemed like a good idea at a time. So at the time, so lots of times KT in this area may not be well thought out or based on evidence or input, and this can sometimes have unintended consequences. The yellow, not necessarily in a research context, is choosing your KT strategies based on some level of evidence, but not necessarily fully formed. And this is often during dissemination at the end. The orange is using knowledge translation methods and questions to a specific applied research area. And the pink is this full realm of advancing the science of KT. So sort of conducting research to sort of understand what we're doing in knowledge translation and how to move this forward. And this continuum speaks to the need for well thought out KT efforts. What do we want to achieve? Why do we need a brochure, an infographic, or to talk to the media? And what's the best avenue to get our research out? So now let's unpack this definition with some practical examples of how KT has been used in practice. So the first is synthesis, and this refers to a variety of types of reviews that seek to summarize the current state of knowledge in that area. So for example, you might be familiar with things like systematic reviews, scoping reviews, etc. And knowledge synthesis is really important in the context of KT, and it's often referred to as the cornerstone. It's at the level of synthesis that we would maybe then move into implementation. So we often talk about judicious KT in the field, where your KT plan should match the significance of your findings. So for example, not undertaking a large systems or practice level change typically based on the findings of a single study. So this is a well-developed area with rigorous methods, so much so that it's often thought of as its own space outside of KT. So knowledge synthesis often helps us to identify this gap. So the gap in research where we need to kind of move from into implementation or dissemination. The second component is exchange, and this refers to the process of active engagement between researchers and knowledge users. So while this isn't a perfect fit, we often align this most closely to integrated knowledge translation. So one of these knowledge users could be patients and families. An example of this was the Shit Happens campaign between surgeons, physiotherapists, and parents here in Winnipeg. And this was a really unique situation where a parent of a child with Hirschsprung's disease started a social media campaign to unite parents affected by this disease. And parents started researching this rare disease, and it led to a series of research projects where parents were co-investigators. In this situation, priority setting differed between parents and surgeons, and by working together, they came to a consensus on priorities. Another example is from Trek, the network that I spoke about a few slides back. And some examples I'll be referring to throughout, just as this is an example I've been personally involved in. So here, that gap that I mentioned earlier was that the majority of children are seen in rural and remote areas of Canada who may not have specific expertise in emergency care for children, or who may rarely see some uncommon conditions walk through the door. So what we heard through our initial needs assessment was one, that they needed point of care tools to tell them in the moment, what do I need to do for a child who walks through the door presenting with, for example, sepsis or diabetic ketoacidosis. We also heard how they wanted this information and on which priority conditions. So the exchange piece here is really the process that was established to create these tools to make sure that they were relevant for the rural context, based on the best evidence, and able to be meaningfully used in practice. So this involved ongoing exchange between a research librarian, a knowledge broker, and clinical context experts to develop the tool, and then ongoing exchange with the steering committee made up of nurses and physicians working in these areas across the country. The next part of the definition is dissemination. And really this is communication oriented. So the goal is letting people know and also working to impact knowledge and attitudes. So sometimes this has a bit of a blurred lines between this category and the next category of application. And this is what many of us are probably most familiar with and is akin to end of grant KT, where at the end of the research process, you're developing targeted strategies to get your research findings out there. These can be referred to as common dissemination strategies that we might think about, like publication and presenting at conferences. But in KT, we really strongly urge to move beyond this to more targeted and evidence-based strategies, as most of our target audiences we know are not going to come across or pick up or read a publication. So you can create tools for dissemination, but it doesn't mean it's going to be applied. So some of the workshops that we offer at CHI include things like developing your ability to communicate via Twitter, how to write an op-ed to promote your research, and workshops around the process of developing a KT tool. And again, back to the TREC example, an example of a dissemination strategy is the packaging of best research evidence into these bottom line recommendations. So these are essentially one-pagers similar to a clinical practice guideline developed by experts in the field and based on the latest evidence of what you would need to know to treat a child who comes in with X condition. Again, just creating these and posting them on a website, little use, but coupled with targeted communication, embedding them into day-to-day practice, and having local champions promote them increases the likeliness of their use. So again, this is an example where dissemination and application may be blurred. Within this network that I'm referring to, they've also developed easy to understand, my slides keep jumping ahead, but easy to understand parent tools for dissemination, which, oh, it's doing it again. But which are promoted in doctors' offices or that play in waiting rooms and emergency departments. Another example of a commonly used dissemination strategy are infographics. So here our media specialist developed an infographic to convey the results of a report developed by the Manitoba Centre for Health Policy, distilling a few hundred pages into a concise one-pager. So again, though, Pat is at CHI here is really good at making us think about our goal and purpose. So a lot of researchers might come to him saying, oh, I want an infographic, or I want this type of tool. So he really does help us think of, why do you need an infographic? What do you hope to achieve? And what is your target audience? So helping you think about what is the best strategy. And again, dissemination and good dissemination can also include that exchange piece. So further speaking to how these different levels can kind of be blurred. So a good example of a situation where end users drove the design of a dissemination tool was the HURT app for young men with mild hemophilia, which is a bleeding disorder. So this started when a physiotherapist, Kathy Mulder, recognized that many active young men were taking a watch and wait approach. They weren't really sure how to determine which bleeds needed treatment and didn't feel that existing resources were suitable. So researchers first went along and developed a self-assessment flow chart, and the young men liked it, but they asked, is there an app for that? So this was a case where researchers went in with what seemed like a good idea, but had they not interacted with their end users, this might have just been another tool for the bottom of the file drawer that wasn't necessarily used. And then finally, the final component of this definition is application. So this is one of the more involved levels of knowledge translation, where the strength of the science, so not just an individual study, but the collective body of knowledge on a topic, warrants active efforts to move knowledge into practice. So application is also often referred to as implementation. And using the TREC example again, I think this really demonstrates the continuum of what KT can look like. So it started with this gap that I mentioned before, that 40% weren't receiving evidence-based care and expressed need from rural healthcare providers. Then priority conditions and preferred ways they'd like to receive, to see and receive that evidence was determined. Then there was that ongoing process of exchange between researchers and clinicians, and then the development and dissemination of those KT tools, the bottom line recommendations, parent tools. And then there was implementation at sites through leadership, training, key champions, and then finally, evaluation of reach and impact. Advancing the science of KT or measuring impact involves using a number of different research methods. And many of us working in KT tend to use mixed methods. But just to take an example, what is the role of KT in qualitative research, for example, and vice versa? What's the role of qualitative research in KT? Well, I think both have an important link to one another. For example, KT methods and resources can be useful tools for qualitative research to plan how you want to share your findings. Similarly, understanding KT and advancing KT science really can't occur without the help of qualitative research. This is the part of the reason, as I mentioned, that many of us KT students take courses not only in quantitative methods, but also qualitative ones, because qualitative methods are a core competency of KT. Also, the two have shared commonalities and principles. For example, in engagement methods, for KT, this would be integrated knowledge translation, which involves co-creating research. Both share those core principles of relationship building and power sharing. So first, looking at the role of qualitative research for KT. Back in 2015, a special issue in the Journal of Qualitative Health Research recognized the critical role of qualitative health research in advancing the field of KT and our understandings of the uptake of knowledge. And really the recognition that the process of knowledge translation is not just about providing information, but that KT is a complex social process that is often messy and influenced by things like local context, relationships, interactions, and things that kind of coupling with qualitative research can really help to get at some of those complexities. Some potential roles for qualitative research in KT that they described included the ability to identify ways researchers and research users could collaborate to translate evidence into new approaches and innovations, and increase the use of research in practice, exploring how research is used and uptake in practice health systems, and to identify conditions for supporting knowledge use. There are a number of different roles that they mention here, but another is improving knowledge translation of qualitative research into clinical and public health practice, which has largely been quantitative in nature. And similarly, if you think of the KTA framework, the predominant framework used in KT to guide the movement of research into practice, qualitative research methods can and should be used at virtually every step of the process. So for example, in the inner funnel of knowledge creation, an individual study could be qualitative in nature. Development of knowledge tools and products, such as those parent tools that I showed earlier, can be backed by qualitative findings and developed using arts-based methods. And then moving into this outer ring of application or implementation, you can imagine how qualitative methods can be critical to all of these steps, from understanding local contexts, assessing barriers and facilitators, and evaluating outcomes. Probably the most useful role knowledge translation might have for some of us as, say, students or even as researchers is an end of grant KT, or maybe one of the areas we're most familiar with. So essentially what to do with your research once you're finished. Or for example, if you were writing up a grant application or your thesis proposal, what should you consider? So end of grant activities can vary in scope and intensity. So often the first kind of level is diffusion, and that's the bare bones level, often referred to as simply letting it happen. So this is a passive form of KT that includes things like I mentioned, publishing in academic journals and presenting at conferences. But here the onus is on the knowledge user to find that knowledge, and it's typically restricted to the academic community. The level of dissemination steps it up a notch by helping it happen. So this includes considering your target audience and communicating your findings appropriately. So as you move along the KT continuum, you begin to more actively interact with end users in developing your dissemination plans and tools. And then some people also talk about implementation as being the highest level of dissemination, which, as I mentioned again, would cross over into application. So implementation is a more purposeful intent to make it happen, for example, by identifying and removing barriers. Oops. As many of you are probably familiar with, if you've ever, well, I'm sure you've all written grant applications or applications for funding, you're often required to include a KT section, but it can be difficult to know what to include in this section and what's realistic and feasible. Some might call for a simple paragraph or two, while others will require a full and comprehensive KT strategy. So in the popular textbook used throughout Canada, they outlined 5 essential ingredients that should be articulated in your end of grant KT plan. So this is outlined on the slide here. So the first is goals and setting clear goals for your KT efforts. So asking yourself questions like, what is it that you hope to achieve? Is your goal simply to raise awareness and spread knowledge? Is it to change a particular healthcare practice? Just remember at this stage that these should be relevant to the nature of your research findings. The second is audience. Who will this research impact and who do you want to reach? Think about the current state of their knowledge, how they might intend to use this knowledge, and what formats or mediums might be best for transmitting this information to each group of end users. The next is expertise. So what expertise do you need to execute your KT plan? Do you have the appropriate representation and skill set on your team? Roles to consider could include people like knowledge brokers, community members, KT specialists, communication and media specialists, and healthcare managers. And then finally, resources. As always, be sure to allocate appropriate resources to carry out your KT plan. So these include both financial resources and human resources. And then, of course, in developing a KT plan, you can also take an integrated KT approach to developing that. So as we've touched on earlier, end users have extensive knowledge that can lead to a more enriched and valuable KT plan. So engaging end users where appropriate in the development of your KT plan can help you reach intended audiences, craft your message, and suggest potentially useful strategies. But of course, be sure to start this engagement early in the research process. But don't worry, there are a number of tools that can help you develop an effective KT plan. For example, in a grant application, or if you're a student, a thesis proposal. So one of the most popular is the Melanie Barwick's KT planning template. And if you check out our blog, I'll provide the link at the end. Carly, our KT manager, has also laid out a number of these different resources. So as I mentioned earlier, CIHR has defined those 2 broad categories of KT. So while I've just talked a little bit about end of grant KT, I'm just going to also touch briefly on integrated KT, which is kind of the area of research that both Dr. Sibley and I the space that we work in. So as I mentioned, integrated KT involves working with stakeholders, knowledge users throughout the research process. So this involves conducting research with rather than to stakeholders or knowledge users, placing equal value on different types of knowledge, acknowledging that different partners bring different perspectives, and it really focuses on research that is action-oriented. So as I mentioned, what is KT? It's a collaborative mode of research. It involves partnership across the research process. It's this partnership between researchers and knowledge users to really co-produce research. And how it's done is through the development of meaningful partnerships. Oftentimes, this is a partnership that might span throughout your entire career. It involves shared decision-making and sort of that attempts to equalize those kind of power dynamics. It involves engagement of those in a position to impact outcomes, or those who the findings might be relevant to. And it's really grounded in trusting and reciprocal relationships. I'm just going to skip over this part just for purposes of time. But the science and evidence base behind IKT is increasingly growing. So back when I started my PhD, we knew that IKT was a good thing to do in principle, but there still wasn't much evidence of its impacts or the strategies used to engage knowledge users in the research process. So this area is growing, but there's still underreporting of outcomes and work to be done to demonstrate impact. And this is some of the areas that both Dr. Sibley and I are working on right now. So just as an example, in a scoping review that I recently conducted looking at research partnerships in child health, we found that 62% of studies reported the outcomes of conducting research in partnership with knowledge users, which is actually pretty good. It was more than I expected, but a lot of this was anecdotal, so it wasn't necessarily based on kind of measured levels of outcomes and impacts. Notably, most reported beneficial outcomes, with the most being the development of relevant and useful research findings, the development of high quality research, increased capacity, knowledge, and skills of both researchers and knowledge users, some positive impacts on the relationships between researchers and knowledge users, for example, synergy, mutual respect, and sustainable partnerships that might carry on past kind of that individual research project. And then also increased acceptability and trust of research in the community. So these are all important outcomes, and some of them might not be the change in healthcare practice, but it's sort of, there are a lot of those kind of relational outcomes that come out of integrated knowledge translation. And then recently, a team by Dr. Heather Gainforth from the University of British Columbia, Okanagan, published guiding principles for engaging in partnership with the spinal cord injury population, a population that she has a long-standing history of partnership with. So some of these guiding principles are starting to emerge to help kind of guide that process of relationship building and partnership research. So some of these are things like partners develop and maintain relationships based on trust, respect, dignity, and transparency, that partners foster open, honest, and responsive communication. Partners recognize value and share their diverse expertise and knowledge, and so on and so forth. So as I mentioned on one of the first slides, there is also ongoing debate about terminology in and across fields that are often hard to distinguish between. So one area, we talked about the general term of knowledge translation, but this is also somewhat true in the area of partnership research or integrated knowledge translation. So despite the relatively recent term of IKT, or I guess it dates back to about 2007, but collaboration between researchers and knowledge users or partnership forms of research is not a new concept. So across various disciplines, there exists a long-standing history of blending these different perspectives. Such terms include, but are not limited to, community-based research, patient engagement, participatory action research, mode 2 research. And this has made studying the benefits of IKT challenging, but also brings up the question of whether we need to achieve clarity on the differences between integrated KT and other health research partnership approaches, or whether there are some unique differences between some of these approaches. So one of our colleagues, Tram Nguyen, started to look at this in a recent publication. And this study found that most participants really emphasized the similarities between many of the approaches, and most found it difficult to align with one specific approaches. So while approaches shared common principles, they did find that the way that they're enacted is contextual and related to the stance of those involved. And there were 4 distinguishing features of integrated KT. So first, they found that integrated KT was the only approach originally developed in a health research context by health research funders in Canada. Second, they found that integrated KT is either considered epistemologically, I always have trouble saying that word, neutral or linked with a social constructivist epistemology. Third, that IKT has typically not been about emancipation of knowledge users, but rather focused on increasing knowledge use, implementation, and impact. So really this application piece. And fourth, that IKT makes explicit the engagement of knowledge users throughout the research process. Similarly, other researchers have started to explore similarities between IKT and some of these other approaches, such as community-based participatory research. So this is an area, at least in kind of the IKT field, where we're starting to look at, are some of these approaches similar? Are they different? What aspects can we kind of pull from each, and which approach is the most relevant based on what you hope to achieve? And then just to close off, we never want you to feel lost in KT. So there are a number of resources out there to help you. And as I mentioned, we're just sort of scratching the surface today. The first is a seminal article by Grimshaw and colleagues back now already almost 10 years ago. But if you're going to read one paper, this is a really great example. It summarizes the systematic review evidence on KT interventions with different user groups. And at the time, kind of where we were at in the science. As I mentioned, our blog, medium.com/knowledge nudge, also has a number of great resources, including foundational KT information, some good posts on theories, models, and frameworks, which I didn't touch on today, a large patient engagement section. And as I mentioned, we've just scratched the surface on KT. So if this is an area that interests you, we also, or Kate also holds a KT graduate course here at the University of Manitoba. And then also one of the most helpful papers I have found is this paper by Proctor and colleagues on writing implementation research grant proposals, and they outline 10 key ingredients that can be useful to consider if you're ready to consider an implementation study, or specifically for how to write grant proposals. And just a few more here at the Center for Healthcare Innovation. We also host throughout more of September to kind of Mayish, but a lunchtime learning series on patient engagement, where they go through all sorts of topics on that. There's also an online tool that has a number of links about how to engage patients and the public within the research process. And then we also have a prep award that helps with funding sort of for engagement prior to submitting a grant application. And then as always, you can always reach out to the KT platform at CHI. And then I have my contact information here. But just to close out, a few key takeaways. Just first, that KT is both a science and a practice, and that at CHR, they emphasize two key elements of KT, being integrated knowledge translation and end of grant KT. And that KT can be helpful to research to maximize the reach of your research, and integrated KT can improve the relevance, meaningful, and hopefully subsequent impact of your research. And then finally, as we know, not all research is ready or meant to be implemented into practice. So most of the work we will do as, for myself as a student or as researchers, will stay sort of in this inner funnel and focused on building that knowledge base. But it's important to know the tools we can use to progress through this cycle and share our research with those who it might impact. So I think I'll stop here for today and open it up for any questions. It looks like we have about 13 minutes left. And as always, our contact information is there should you have any questions.